So it's my pleasure to introduce Dr. Yazan Duwayri. He's professor of surgery at Emory University. He's the medical director of the Heart and Vascular Service line at Emory University Hospital. He joined Emory in 2011 after completing his vascular surgery fellowship at Washington University in St. Louis. And he specializes in endoluminal and open vascular surgery with his main focus on complex aortic interventions. He also serves as a co-director of the Emory Aortic Center and leads the Emory participation in several device clinical trials. And his current research focus is in outcomes and quality improvement in vascular surgery. And today, Dr. Duwayri will be talking to us about management of peripheral artery disease in women. Thank you for being here.
Good morning, everyone. Thank you very much, Carolina and the GIOMA, for the kind invitation to be here. It's an honor to give the first talk in this meeting. So I'll try to cover a very broad topic, which is management of peripheral arterial disease in women. And in general, well, I'll start with my disclosures. I do not have any relevant financial disclosures, but I'll try to cover a few things here, largely related to PAD, peripheral arterial disease in general, as it relates to its detection, treatment, and how we evaluate the outcomes, and looking at the natural history of peripheral arterial disease. And that will be kind of the focus of the initial several slides. And then we'll move towards a little bit of evaluation of the disparities in peripheral arterial disease management and treatment as it relates to identifying it in women, and how this has outcomes implications on women's vascular and cardiovascular health. To start by broadly identifying how we define peripheral arterial disease and how we look at its stages as it occurs in patients. Peripheral arterial disease is defined as occlusion of lower extremity or restriction of lower extremity blood flow, usually as a result of atherosclerotic plaque burden accumulation. Like every other disease process, it starts in a mild phase and then progresses to a severe phase. Now, there are several methods of classifying peripheral arterial disease and several staging systems, and these are two examples of them. One is called the Fontan classification, and the other is Rutherford classification. I think the numbers and the classification are not as important as the broad understanding of what they entail. In general, the earlier stage is an asymptomatic stage of peripheral arterial disease. Asymptomatic meaning patients do not present with any symptoms, but this can be detected with screening tests. Next is a stage where claudication happens. Claudication is lower extremity muscle exertional pain that manifests upon walking or running. And it can range from mild to moderate to severe. Beyond that, if a patient starts presenting with ischemic rest pain, pain at rest in the forefoot, in the toes, or in the foot itself, this gets classified as chronic limb-threatening ischemia, CLTI. The more it progresses, people can have tissue loss manifested as ulceration or gangrene in the lower extremity, and this is the most severe form of peripheral arterial disease. So again, to wrap up this classification, the initial stage is asymptomatic peripheral arterial disease, identified by evaluating the ankle brachial index, comparison of the lower extremity blood pressure to the upper extremity blood pressure. And if you detect an ABI of less than 0.9, then it is safe to say that the patient does have peripheral arterial disease, and then talk about the implications of that. So the implications of each of these stages can be looked at as implications to the extremity itself, to the leg, and implications to impact on life expectancy. From an extremity impact, asymptomatic peripheral arterial disease rarely result in any lower extremity loss or progression. So this is important as we talk about what we need to do as we identify this problem. However, there is an impact on life expectancy. Patients who do have peripheral arterial disease have a higher risk of cardiovascular events and cerebrovascular events, as well as risk of mortality. So the treatment of these patients, once identified, is really risk factor modification, weight loss, exercise, smoking cessation, lipid-lowering agents, blood pressure management, as well as antiplatelet therapy to look at prolongation of life and limiting the events of cardiovascular morbidity. Intermittent claudication, again, exertional pain in the lower extremity associated with restriction of blood flow as identified by a low ankle brachial index. Now, this does have an impact on the lower extremity. It impacts the quality of life as it limits the walking capacity of patients, limits their ability to exercise, perform activities of daily living, as well as limit their working capacity. There is a very low risk of limb loss in patients who have claudication. It's only 1% per year. However, the impact of on life expectancy is also more significant in patients with claudication, just like it was more significant in asymptomatic PAD patients, with significantly elevated risk of cardiovascular and cerebrovascular events at a rate of somewhere between 2 to 3% per year. So again, the focus should be on medical management and improvement of the risk factors. Now, I want to just mention this briefly. Not all patients who present with lower extremity symptoms are a result of atherosclerosis. As we talk about women's vascular disease here, it's important not to focus on just the classic patient, the elderly, the smoker with high lipids. Lower extremity arterial disease can occur in the athletic, young, non-smoker patient. It is a result of other conditions such as vasculitis, prior trauma, identifying congenital abnormalities such as popliteal entrapment, or compression abnormalities such as endofibrosis of the iliac artery. Those are things that can get exacerbated with athletic activity. The endofibrosis of iliac artery is known in female athletes who are cyclists. Popliteal entrapment are in runners. So as we look at lower extremity arterial disease or lower extremity symptoms, it's important to evaluate lower extremity perfusion and consider imaging to evaluate those unusual causes. They are rare causes, but we are now starting to identify them and treat them more frequently. This is just a picture showing what popliteal entrapment syndrome again shows. It is related to the enlargement or the hypertrophy of the medial head of the gastrocnemius muscle in the calf, or sometimes due to abnormal insertion of the muscle head behind the knee, resulting in compression, abnormal compression of the popliteal artery. Now, the most severe stage is chronic limb-threatening ischemia, CLTI. Previously, we used to call it CLI, critical limb ischemia. But now, to emphasize the chronic nature of this disease, we move towards a different terminology. The impact on the extremity in patients with the CLTI, again, those patients are those who have ischemic rest pain, pain in their foot when they are sleeping or resting and not moving, and those patients who have ulcerations or gangrene in the foot. There is a significant impact on the extremity, actually a 30% annual amputation rate in those patients. So those patients need to be treated urgently with revascularization to improve their limb outcomes, and also a very significant impact on mortality. A quarter of these patients will die within a year if untreated. So there's a significant impact here as we kind of focus on treatment for limb outcomes as well as life outcomes. Again, just kind of looking at what the fate of those CLTI patients with time is. Most of those patients will undergo revascularizations. Most of those patients will eventually go to a vascular surgeon and have either an endovascular or open intervention. Some patients will not be found to be candidates for that. But regardless, out of all out of all those patients, really around 30% of them usually end up if they end up without treatment, only 30% of them will be alive with 2 limbs at the end of the year. So there's a good chance of either losing an extremity or not surviving beyond 1 year. Now, there are several classification systems if a patient reaches the degree of gangrene. When we look at the limb and look if revascularization is an option, the SVS, the Society for Vascular Surgery, has developed a Wi-Fi classification looking at the wound, infection, and foot ischemia combination to look at whether revascularization is warranted or a patient is better served with primary amputation and living with a prosthetic limb. So this is kind of one of the angles or the lenses that we use to look at patients who do have chronic limb-threatening ischemia. I want to emphasize this point here, the natural history of peripheral arterial disease. Not all patients who present with chronic limb-threatening ischemia progress prior to that through the different stages of claudication. Some patients' initial presentation will be with foot rest pain or foot gangrene, particularly now as patients have limited walking capacity due to other issues such as back pain or obesity or things like that. Some of them, they'll just present directly with chronic limb-threatening ischemia. Not all patients progress through all those stages. So it is important, regardless what stage the patient is in, to emphasize on the early diagnosis, early detection, and aggressive risk factor modification with medical therapy. Again, to kind of go over what I just said, looking at 5-year outcomes of patients with peripheral arterial disease, those are the patients who either have claudication or asymptomatic peripheral arterial disease. Their risk of amputation or leg loss is very small, 1% per year, 5% over 5 years. But the cardiovascular morbidity and mortality is high. Mortality of somewhere between 2 to 3% per year, looking at 10 to 15% over 5 years. So again, emphasizing the importance of risk factor modification. Critical limb ischemia patients, as we said, around 30% will lose their legs. 25% will end up with mortality at 1 year if left untreated. Now, what arteries are involved in peripheral arterial disease? Well, this has been evaluated using multiple anatomic studies. This is just one example of them. And all lower extremity arteries can be involved. But for patients with the most significant chronic limb-threatening ischemia, looking at the superficial femoral artery, popliteal artery, and tibial arteries, the infrainguinal disease below the inguinal ligament, these are the ones who do present with the most severe disease. Treatment is either by open therapy or endovascular treatment. The differences are obvious. So big open surgery, open leg bypass is what you see on the screen here, big incision, and endovascular therapy is just a minor puncture. Many differences in safety, short-term results, patency, and all of these kind of go into the formulas in which we try to offer patients different options of interventions. Now, endovascular options are so many. They've just, every year there's a new endovascular option for those patients. Now, the problem with all those endovascular options is that there is very limited data comparing them at each, as they develop to open surgery and also very limited comparisons, effective clinical trials looking at comparing those endovascular devices to each other, as well as looking at comparing them to open therapy. So keep that in mind as we talk to patients about the options, particularly as it relates to the longevity of the treatment option that is being offered. Just kind of to summarize a little bit of what treatment options exist. So let's say a patient with aortoiliac disease, the suprainguinal obstructive disease above the inguinal ligament. Those patients can be classified depending on the degree of occlusion. They can be offered a very good operation called the aortobifemoral bypass with very excellent long-term results. However, it is a very morbid operation involving aortic clamping and revascular and bypass to both groins. So excellent patency, but a morbid operation. Alternatively, if the patient is too high risk, you can offer an axillary bifemoral bypass, does not require aortic clamping, or a thoracic bifemoral bypass. So all of these are options for iliac artery disease. Iliac artery disease can also be treated with endovascular strategies. This is a patient with bilateral iliac artery occlusions. As you can see there, you can see the aorta at the top, and then occlusions as pointed by those arrows. These patients can also be offered effective endovascular therapy with good patency rates at around 90% at 5 years with iliac stenting. And this is what iliac stenting, how it looks like. You cross the occlusion, you place stents, balloon expandable stents, usually with good inflow restoration. In the iliac arteries, it has very good patency rates. Infrainguinal disease is a little harder to treat because patients do have multi-level disease when they do present with infrainguinal disease. The classic treatment is this relatively morbid operation of lower extremity bypass using saphenous vein or sometimes prosthetic conduit. Saphenous vein is has a much better patency rate compared to prosthetic conduits, but it is still the gold standard to which all endovascular interventions is compared. Endovascular interventions, as I mentioned, there are so many. POBA, plain old balloon angioplasty, or just stenting, atherectomy clearing the plaque, covered stents, drug-eluting stents, bare metal stents, all of these are endovascular options, and the treatment is just like what we talked about in iliac artery interventions. You cross the occlusion, you put a balloon or a stent or use an atherectomy device and treat this occlusion accordingly. And this is a patient with superficial femoral artery occlusion where the treatment included crossing the lesion with a wire and ultimately treating it with a stent. So the longevity of those endovascular interventions is still not as good as open surgery, unfortunately. Now, and to the degree of, the patency of a superficial femoral artery stent is only at around 50% at 1 year. So requiring multiple reinterventions is an important thing as we talk to patients about the surgical options, and also as now we talk about the cost of caring for those patients, and the fact that sometimes their follow-up may be limited due to many factors. So as we talk about limb outcomes, we have to keep in mind the likelihood of secondary interventions to maintain good limb outcomes. So just a few terms that are important as we talk further about the implications of therapy on patients with lower extremity arterial disease. These are kind of the endpoint definitions that we usually use. I will point out to two. MALI, major adverse limb events, this as it relates to redo surgery or loss of the limbs, and amputation-free survival. These are the two things that really matter to us as vascular surgeons, that the patient is living and living without an amputation and living without the need for major adverse redo lower extremity surgery. Now, having given this very long introduction, I think we can talk a little bit about how this can be applied to disparities in PAD care, particularly as we talk about women's cardiovascular health. I think there are issues that I will present here that relate to each of these aspects: detection, intervention, and outcomes. Detection, as we said, the easiest form of detection is an office-based study called ABI, Ankle Brachial Index. The first issue with with looking at detection in women with peripheral arterial disease is that the awareness of PAD is still low in both men and women, despite all attempts by the American Heart Association, by the Society for Vascular Surgery, Society for Vascular Medicine, we are still not able to get this knowledge delivered to our colleagues in primary care as well as in emergency department. And as a result, also, we've always looked at peripheral arterial disease as a male problem. And we've, until very recently, until the last 10 years or so, we forgot to kind of look at, kind of get out of the vision of looking at the patients in their 40s or 50s with peripheral arterial disease and looking at the whole burden of peripheral arterial disease in the United States and in the world. So the prevalence, the burden of peripheral arterial disease is much more in women, largely because of the fact that the distribution of women and men in different age groups, and the fact that with increasing age, people do have a higher likelihood of developing this problem. 10 years ago, there was a call by the American Heart Association to look at women and peripheral arterial disease in a different lens, and really kind of allowed us to not look at just the incidence rate at different age groups, but really look at the actual burden, how many patients are impacted. So this took us from just looking at the percentage in each age group to actually the number of patients in the United States with peripheral arterial disease. And as you see, this kind of changed how we look at the prevalence of peripheral arterial disease, and a very unrecognized group is older women who do have a very high prevalence of this problem. A second issue in disparities is that PAD disproportionately affects women of color. And in this study looking at women above 50 years old, it was clear that African American women have a higher likelihood of having peripheral arterial disease, higher incidence rate of that compared to non-Hispanic whites and Hispanic females as well. So this is a disparity that is still recognized and under-managed until now. Now, there is a significant knowledge gap in risk factors. Again, we've always looked at a smoker male being the problem patient here. But what we have failed to recognize is that, in women in particular, non-smoker women have a higher risk of PAD development than non-smoker men. The life expectancy is longer, and therefore more older patients impacted by this problem. Atypical symptoms are very common in women with peripheral arterial disease compared to the classic calf claudication symptoms in men. So I remember a pharmacist colleague that I once treated who had very vague lower extremity symptoms, knee pain, foot pain, and completely healthy, and I never expected her to have a positive study, and she did eventually when I evaluated her further. And I did that further evaluation, I admit, was for social reasons, because I did not want her to leave without having an ABI study in the vascular lab, which did eventually reveal a very positive study and subsequent need for aggressive risk factor modification. Also, latent phase is more common at women. Women do present in a later chronic limb-threatening ischemia phase and without passing through the stages of claudication. The other thing is that there's a little bit of a diagnostic dilemma that I have not figured out yet, which is that women in general have lower mean ankle brachial indices. And you wonder if the diagnostic threshold should be adjusted accordingly, or if we should just keep the existing definitions. And now they do, and believe me, I see lower extremity blood vessels frequently. They do have smaller blood vessels, and I wonder if this, and this has implications on the outcomes of surgery and vascular interventions, as well as makes us wonder if test results have to be adjusted as we look at women. Now, vascular biology evaluation is very limited in females. Most of the translational and basic science tests are done in male lab animals, and So not only clinical trial enrollment is limited in women, but also in evaluation of vascular biology. So novel risk factors, other than the classic risk factors for atherosclerosis, need to probably be evaluated a little further. So moving a little bit towards looking at interventions in female peripheral arterial disease and disparities in care there. Number one, there is a sex bias in clinical trials, not only in peripheral arterial disease, but really in every treatment evaluation currently in medicine. In peripheral arterial disease in particular, there is underrepresentation in all randomized trials. Those that evaluated just mere medical therapy, exercise therapy, endovascular treatment, and open surgery. All randomized trials have very significant underrepresentation in women. The other thing is that we know that women do get less focused on optimization of medical therapy. They are less likely to get referral to a vascular medicine specialist or a vascular surgery specialist or a cardiologist. And they are less likely to be prescribed aspirin, statin, and blood pressure modifying agents, as well as exercise therapy. So that gender gap does even exist more as we see patients with advanced lower extremity peripheral arterial disease, particularly CLI or CLTI patients. Now, another thing is, again, we moved from knowing that patients, that the burden in of this disease, in the past we used to think that the burden of this disease is really focused on males, and now we have started to realize that there are actually more women in the United States living with peripheral arterial disease, and more so with symptomatic peripheral arterial disease. But it's interesting in this evaluation of looking at Medicare data, looking at how there are sex-related disparities in interventions between males and females. Females get less operative interventions than males. And this exists in all vascular interventions, including aortic aneurysm treatment, as well as lower extremity arterial disease treatment. It does not exist in carotid interventions for some reason, but significant and persistent over time. So it has not improved over time either. So you can see it again, with the exception of carotid artery disease treatment at the bottom of the screen. PAD and aneurysm interventions are much less performed in women. Moving to outcomes. Again, when we talked about what important outcomes matter to us as vascular surgeons, MALI, major adverse limb events, and amputation-free survival. Those matter as we talk about the longevity of the treatment options that we are providing. But also, as a surgeon, what matters to me a lot is that the short-term outcomes after surgery and the mid-term outcomes. So there are outcomes disparities even in those patients that we do intervene on. So access complications when we do endovascular therapy, whether groin access or sometimes we do retrograde pedal access from the foot vessels, because what happened is we discovered that there were so many access complications when we intervene on women. You get more hematomas, you get more femoral artery closure. So we said, all right, well, maybe if we should just avoid the groin altogether and move to radial artery or dorsalis pedis artery. Now, there are still more pedal access failure in women. Again, looking at this using a VQI or vascular surgery registry. More hematomas and requiring surgical intervention, more aneurysms requiring readmissions or observation. Now, on the surgical side, we do have a higher incidence of wound complications, and we do have a higher incidence of surgical bleeding requiring intraoperative and postoperative transfusions. At the short term, women have higher short-term major adverse limb events after surgical bypass. The bypass loss is higher. The amputation rate after surgery is higher. and discharge to a facility other than home is more likely in women. Looking, which kind of brings to our attention the importance of other things other than looking at size of blood vessels, looking at how we are providing overall social care and medical care to this underserved population. It's interesting that there is not much difference or unidentified difference in mortality after surgical bypass. Patency, this is interesting. You know, when we looked at long-term Medicare data, and this was a very nice article by Dr. McKinnigal from UNC. Endovascular patency. Endovascular, so if you take away the short-term results, the increased risk of access complications, endovascular patency results are better in women. Surgical patency results is inferior. So again, you know, you go back to the short-term results of surgery having higher really limb adverse events, and then you look at patency rates being better in endovascular therapy in men, and you know, kind of lets us take into consideration the fact that maybe we should look at endovascular devices with lower profile to be used in women, knowing that they do respond better to endovascular therapy, limit the short-term complications, but allow them the benefit of longer-term patency that they do not enjoy with lower extremity bypass. This is again showing the relatively equivalent patency, despite the increased disease severity in women. And this applies to whether it's infrapopliteal in the tibial arteries or in the superficial femoral arteries and popliteal arteries. This was an interesting study performed by one of our fellows looking at a single institution experience where she ended up practicing afterwards in Wake Forest. But it looked both at men and women and found that lower extremity bypass surgery has improved patency if the patient was labeled as married. Now, interesting here, only 20% of those patients were women. And the problem, of course, is that you don't know what married means. I mean, it does not really reflect whether a relationship is good or bad. But that is an important thing, as pointing us towards looking at a different from a different angle at our patients before intervening and looking at what social support exists. Limb loss rate after surgical bypass revascularization is still higher in women, and but the long-term bypass still has mixed results. Another thing is, we've kind of moved now towards giving, we used to give just aspirin, then we moved towards giving dual antiplatelet therapy to all of our patients, and now we're adding Xarelto or other anticoagulants for risk factor reduction. So it's important to look at where we stand there. So this is still in press, but it's important to see that the long-term bleeding events in patients with peripheral arterial disease is higher in females, and that looks at all causes of bleeding. So again, modifying not only, kind of having, looking at optimal medical therapy in a different way, not only at surgical therapy in a different way. GI bleeding, cerebral bleeding. So I tried to cover, again, broadly peripheral arterial disease treatment, detection, and management, and also look at a little bit of the disparities in females. So in conclusion, I want to point out that, PAD is underdiagnosed in females. Women are underrepresented in all clinical trials, particularly PAD trials. And this does require specific effort to address this disparity. There is a lack of evidence-based guidelines for female patients, and there is a need to develop these. Now, one thing we did not talk about is that there is a complex interplay of gender identity and socioeconomic status and race that remains poorly understood in the PAD population. And of course, we do have to address these root causes many ways by modifying our clinical practice methods as well as looking at how we develop our clinical trials. Thank you very much, and I hope I was able to cover what I was assigned to do. Thanks.